of trauma, like how we approach a trauma patient. Uh, my opinion, I'm not an expert emerge doc from, New Orleans Trauma Center or anything. I'm just a regular emerge doc like the rest of you guys are going to be when you're done. And if I can communicate anything, it's that you want to get good at the basics because trauma can be so variable, right? Like you can have anything run over by anything, or you can have anything broken or punctured or crushed. And I think whether it's not that big a trauma or it's a really big trauma, I think one of the most important things is to just always treat it the same. So that's something that's helped me a lot. Always try to keep it simple so you don't make mistakes. Any questions before we get started? And if you do, just speak up because I can't see everybody. So we're just going to talk for an hour, and we're just going to talk about the primary survey. So then we'll do another lecture later on about the secondary survey, and you'll get different talks about trauma for sure over the period. But so we're going to talk about the primary survey and what do you do in a primary survey. So has anyone got to be, the primary survey doc yet in a legit trauma? I like to think of it sometimes as there's like the leader and then there's the worker bee. So that was always the way I like to do it, or still like to do it, is the leader sort of stands at the foot of the bed and barks orders and keeps track of things and writes down things, and the worker bee actually physically is at the bedside doing all the physical exam and shouting out what they find. So that's the way I like to do it. So case one, so I'm going to share a case that I had just recently, and one thing I'd really like to acknowledge is I've done quite a few traumas in Prince George and IMO and as TTL and things, and doing a trauma case in a big hospital with a really good team is great, frankly. So when you have the anesthetist show up and the orthopedic show up and the general surgeon show up and the intensivist show up and you've got fellows and senior residents and lots of nurses, that's one type of trauma. And when you're doing it in a small community, like I'm in Powell River, which is single coverage and maybe 2 nurses, sometimes 3, trauma can be a very different bag of worms when it's more single coverage. So I want to share a bit of the rural perspective on trauma because it is quite different than like a trauma center approach. So just last month, there was a case of a adult woman on warfarin who got run over in the yard, so by a vehicle, run over the belly. So get the pre-arrival notice, and sometimes trauma is just dropped off at the door. Like many times in Prince George, people were shot or stabbed or things, and literally just kicked out of the car at the front door of the emerge. We called it like the homeboy ambulance drop off. But more often you get a bit of an alert. So the paramedics will call ahead and say, hey, we got this case and it's a trauma. And so the first thing you want to do is get ready, right? Especially in COVID. I mean, you want your mask on, you want your gloves on, you want your gown on, you want to prep your team. So, and you want to call for help. So if you are in Prince George and you have a bunch of help, then that's great. You want to do a trauma code activation, right? Like a level 2 trauma or level 1 trauma. But if you're in a place like Powell River or Mackenzie or wherever else you guys are, it's nice to call anyone else. So you call your friends. If you have an RT that can come in, if you have lab that can come in, if you have X-ray that can come in, if you have a general surgeon or an internal med or another emerge doc, GPA, try to get those people to come in because it often takes a lot of hands. You want to get your personal protective equipment on, obviously. Sometimes people have sharps on them. You can get poked. Sometimes people are spitting out blood. Sometimes people are agitated and vomiting, and it can be all the things, right? So you want your PPE, and then when they come in, I like to get the story from the paramedics. So usually there's a lot of commotion, a lot of noise, but I think it's worth. The other thing I like to do, and it's sort of like a safety little thing for me, is I always try to grab a clipboard with a piece of just blank paper on it and my pen. There's so much to write down when they first come in. So I really like not trying to memorize it all and not trying to keep it all in my head. So I really like to grab a clipboard, put a piece of paper on it, get my PPE on, get the team, say, okay, you're going to be on airway, you're going to be on primary survey, I'm going to be the lead. Try to get a nurse with a trauma record. Most hospitals have a trauma record where they can click through the different parts. So that's what you want when you get pretty slick. And then the patient comes in, and the paramedics are moving them over, and the nurses are getting the monitors on, and they're undoing the seat belts, and there's usually blood, and there's usually callers, there's usually screaming and moaning, there's usually upset family. But I try to take even just 30 seconds to get a good story from the paramedic. So what do you got here? Well, I got a 60-year-old female, otherwise a history of AFib, on warfarin, run over by a vehicle, crushed, GCS of 5, not breathing, bagging, bloated abdomen. Well, that summarizes things pretty good, right? You got a pretty good idea. So let's get them over on our bed, and I always think of it the same way: IV O2 monitors, advanced airway equipment to the bedside. So advanced airway equipment to the bedside is always there, basically in any trauma room in probably Canada. like Prince George especially. I mean, you have that great crash cart and the airway cart. And then the nurses try to get IVs pretty quick, which is great. If you can't get an IV, put an IO in and don't apologize for it. It's really easy to do. It's quick. Just put it in the top of the tibia or the humeral head if they're a bit bigger. You want to get some oxygen on and get the paramedic story and try to get the first set of vitals. So it's pretty easy to panic in these situations, especially when you're just starting out. But as you get better at it, you just see more and more and more of these. You really want to try to keep it organized. And keeping it organized is not that hard, but just do it the same way every time. And when you guys are starting as residents and you get the chance to see like a traumette or a mild trauma, just treat it like a real trauma. Why not, right? Like, think about IVO2 monitors, advanced air equipment to the bedside. Think about getting the paramedic story or the nurse's story. Think about getting your chart or whatever you're going to write on. Think about who's going to do the primary survey and who's going to be the leader. Because I think just practicing those basic skills makes it so much easier when it's a legit trauma. And then you just want to do it the same way every time. A primary survey is just A, B, C, D, E, F. Have you guys done ATLS? Perfect. So yeah, I mean, this is essentially ATLS. So we're just going to do a little bit of review because you can't really review it enough. So what I like to do is, let's say if I'm at the foot of the bed and I've got someone else being the worker bee, I like to see the worker bee go up and start with A and be like, "Hey, Paul." Say A. So the airway is patent, protected, and they're speaking full sentences. Like, that's what I want to hear from the worker bee. And if not, then something needs to happen. So what are the kind of things if people want to, do people want to speak up, or should I just keep talking? I think people could probably speak up. So what are the kind of airway problems you're going to run into in trauma? I know it's a pretty wide thing, but like, what are you going to do about it? So if their airway is not patent, it's not protected, they're not speaking full sentences, what are you going to do? And I know it's kind of a vague question, but anyone want to take a stab at it? Like, what are your interventions?
Temporizing measures, so you can put in like an NPA or OPA.
Totally. Thanks, Paul. All those things for sure. You can do it. You can, is it bloody? Is it not bloody, right? If it's bloody, you want to try to get a suction in there. If they're almost always collared, but if they're not collared, you can do a chin lift. Those are pretty limited, but suction is great. You definitely want to try to get suction, if not 2 suctions, ready before they get there, so you can suction out the blood and the broken teeth. And then, yeah, Paul, just like what you said, you can get an NPA or an OPA. If they're going to tolerate an NPA or OPA, they're not doing well, right? Like, have you ever tried to put one of those into someone that's awake? Like, they'll whack you because it's so uncomfortable. So yeah, I generally do an OPA first. NPA in trauma is always a bit risky, right? Because if they have a facial trauma at all and they've injured the cribriform plate, and I've seen that happen actually twice, where people put an NPA into a facial trauma and it actually went up into the cribriform plate. So I think it's actually pretty easy to do in a facial smash. So obviously don't do an NPA in a facial smash if you can help it. And OPAs are so much better anyway. So I'd put the OPA in and start bagging it. And that's what we did in our trauma case. But again, you're pretty sick if you're getting an OPA and you're bagging, right? And then you can put oxygen on. I don't think BiPAP has a big role in trauma. I mean, really, you're going to be dealing with like either whether it's pulmonary contusions or fluid in the lungs, and BiPAP's not really the answer. You're going to have to go to a definitive airway. And so LMA is fine, intubation is fine. So we're going to talk about a little bit about intubation in trauma. So has anyone intubated a trauma patient yet? It's a little different. So I'm sure you've all intubated lots of people in the OR where they're fasting and you have time and it's quiet and
Or
there's
is
music.
it something that you can do from your end? Okay,
Oh, say that again?
okay.
Is that someone that's just not muted?
I think Stan just wasn't muted.
Okay. So yeah, so I think we've all intubated people in the OR, right? Like nice and controlled and the music's playing and it's enjoyable and you've got backup. Intubating a trauma patient can be quite different. It's a crash airway. They've often been eating and drinking. They've often got some facial trauma. There's maybe a broken tooth. There's maybe some blood. There's a lot more emotion usually, and it can be pretty tough. So let's talk a little bit about that. So I want to give a plug to, I would say, the best book in emergency medicine, bar none, is out of Halifax. George Kovac and Adam Law. They were like mentors of mine when I did my EM out there 7 years ago, 6, 7 years ago. And this book is great. I think it was Tees and Paul. It's only like this thick. It's not very thick, and you can read the whole thing cover to cover, and it talks about airway management for geriatric, pediatric, difficult airways, trauma, first attempt, second attempt, all that thing. But it's really basic stuff. It's not like FRCP anesthesia stuff. It's basic family med emerge airway stuff. So I'd highly encourage you to get this book. It's great. Pardon me. And they talk about one thing that's probably one of the most important things about intubating trauma is when to do it. So I think we've all looked at patients and thought, oh, you need to be intubated for sure. But have you guys ever been at a bedside where you're like, I don't know if you need to be intubated or not? Like, I'm really not sure. I'd like someone else to do it and it be done, but I don't know. I'm not sure. So has anyone ever struggled with that? Like, can I intubate this person or no? And a way, like, what are the indications for intubation when you're not really sure?
Yeah, for sure. I remember a patient, Dr. Blacklaw's, they had the emerge in Prince George when I was on CTU, and he was just sort of like, I think we ended up diagnosing him with like CHF, some sort of cardiogenic shock, and anyways, he was declining slowly, and we were like, oh, what's kind of going on? And it essentially came down to the GCS score, and it got below 7. Like when you actually did like a proper GCS scoring on him, it was like, oh no, okay, he's 7 or 6 or something like that. So we opted to take him over to the whatever room we had to use for isolation and then tube him.
Great, thanks, Paul. Yeah, so I mean, a low GCS, assuming you're probably not protecting your airway very well with a low GCS too, like that, you probably heard like, GCS 8, got to intubate kind of thing. That's never made it into my like practical knowledge, like practical working skills, but maybe it should have. But if you're not protecting your airway, like if you're decreased LOC to the point where you're not protecting your airway, then for sure, I think that's an indication. Any other indications?
I mean, like if a patient appears to be in respiratory distress, they're hyperventilating, there's nostril flare, there's tracheal tach or diaphragmatic breathing, or their SATs are just low, or you're going to run into impending airway difficulties like an anaphylactic shock patient or someone who has really bad asthma that's not responsive to your treatment, then those are situations that you kind of judge from cases to cases and make a decision.
Perfect. Yeah, you said a lot of the things there right there. So, someone like an asthma or COPD or someone with an obstructive pattern, like that's one indication. If you can't ventilate, if you're not ventilating very well or you're not oxygenating very well, those are indications. And like you mentioned, an anaphylactic shock with an airway that's probably not going to get any better. You're looking at an obstructive problem. So I'm going to share the 4 Ps, and I stole this right from the book here. But I think the 4 Ps are always what I use in my mind. So A, are they protecting their airway or not? So not protecting. So are they gurgling blood? Are they gurgling saliva? Are they spitting up? Are they vomiting? Are they just decreased LOC? Like, is that airway not protected? I wish it was more obvious. And I really wanted to try to communicate that it's not always obvious. And you're going to be standing at that bedside and be like, oh man, I don't know if I can do this or not, if I should do this or not. And just think of the 4 Ps. If they're not protecting, then intubate them. If they are protecting, then give them a bit more time. The other thing would be patency. So do they have a patency problem? Patency is, like you mentioned with anaphylactic shock. So you have a big tongue, do you have big lips? Do you have huge tonsils? Do you have a neck trauma with expanding hematoma? Do you have a stick in your throat? So any sort of patency problem, right? Is there a problem with the tube where the air goes? That's an indication. The other one that you mentioned sort of with the CHF or the heart failure or the respiratory failure is, do they need positive pressure? So are they basically not venting? Like they're not breathing essentially. So is their CO2 going to become really high? And we've seen that more in like medical patients, right? Like CHF patients with classic or COPD, their CO2 can get quite high and they get essentially obtunded, like they need PEEP. And lots of people need PEEP. So yeah, that's an indication if they're not essentially breathing very well. My favorite, the last one, is the presumed worsening course. So sometimes you're looking at this trauma patient, you're thinking, well, they're protecting their airway, and their airway does not have a patency problem, and they don't really need PEEP, like they don't have a positive pressure problem, but they're getting worse. Like this patient, for example, run over by the car, like they're going to the OR for sure. Like they need a laparotomy, like a trauma laparotomy. And that's a presumed worsening course in my head. So are they going to surgery? Are they going to transfer? Are they going to go to the CAT scanner? That's another one. So if you're looking at someone that's agitated, like let's say you're agitated from head trauma, you're agitated from drugs or alcohol and trauma, and there's no way you're going to sit still for a pan scan, which is really what you need, you're getting intubated. and that's a presumed worsening course justification in my head. Any questions about the 4Ps? The 4Ps are great. Uh, I just want to really throw out a plug that like intubating is really easy until it's not, right? Like, and until you feel like that pressure of almost missing an airway or not getting it the first time, it can change the whole thing. Like, I'm a very overconfident person probably, and have intubated lots and lots of people, and I feel cocky about it maybe or overconfident about it. But like at least 5 times over the past 7 years, I've gotten airway problems where I couldn't get it, and then I couldn't get it again. And there's that feeling in your stomach, you're just like, oh my God, this person's going to die potentially if I can't get this tube in, and you're starting to bag, and then the bagging's not going well, and then the whole thing can spiral. Um, so no, I'm no expert in intubating or things, but I've done the courses and stuff, just like you guys are going to do the courses. But just that feeling of that pit in your stomach where you can't get the airway and you can't get the tube, and then their oxygen stats are going low, and then maybe the nurse you're with doesn't really know much, like they're kind of green, and maybe the friend that you called isn't quite there yet. And then you start questioning, like, oh boy, did I need to do that quite then? Like, could I have waited a little bit for the next person to come in? Could I maybe have waited for the GPA? Could I have done the meds a bit different? Because you push those paralytics, right? You push the propofol or the ketamine or the rock or the sucks, and yeah, the whole thing can become quite stressful quite quickly. And even if you've passed a tube 100 times on a dummy or passed it 100 times in the OR, like when you have a high emotion room where people are crying and there's blood and there's suction and there's noise and there's lots of people and there's a bit of panic and you can't get that tube, it's not pretty. So my point of that sort of story is just make sure that you have an indication, a justifiable indication, because inevitably these airways are harder than you think sometimes. Sometimes they're easy, and they might be easy for a year, like a year or two. But then you have one of those bad ones and you think, oh boy, I sure hope I had a good reason to do this and I wasn't just taking the airway because, with a light indication, you know what I mean? Does that make sense? Because airway can get hard pretty quick. So a little bit about intubation meds. I think I've pretty much only used ketamine and rock for probably 99% of everything I've ever done. So you'll find people that like only use etomidate or only use sucks. I think it's like lots of things in medicine. When you see lots of people do it differently, then it can be done lots of different ways. So I find ketamine is great. I've used ketamine for basically everything. It doesn't drop the pressure, which is great. And in trauma especially, you don't usually want to drop the pressure, right? And then I use rock just because I find it more comfortable with it. It does last a bit longer. So if I've had, like, I missed an airway once on rocuronium and had to bag for 10, 15, 20 minutes, and then the anesthetist said I should never use rock. I should use sucks because it does wear off a bit faster. So, some people really like sucks because it wears off a little faster. In the same breath, you're basically bagging for like 20 minutes versus 30 minutes. So you're still bagging a long time. So anyway, that never really held up for me. Sucks you want to avoid in renal failure, hypercalcemia. I gave sucks once to a dialysis patient before realizing they were a dialysis patient. And I think their potassium was like 10 when I got it back. So that was a big mess up. Yeah. And so it's possible to make these mistakes. Like you think when you're sitting here in your office, well, I'd never give sucks to a dialysis patient. What an idiot. But I'll tell you, it can be harder than it sounds right in the moment. And anyway, so things can happen like that. So yeah, I just avoid sucks because I don't think I need it. But I use rock and ketamine for basically everything. I use propofol if I want to drop the pressure in, let's say, something that you need to drop the pressure, like a hypertensive emergency, or it's not something like a STEMI that's getting sick with high blood pressure that you want to do a lytic for, or stroke that you want to drop the pressure or something like that. But I rarely use propofol for intubating in trauma. In fact, I probably never would. Propofol, like in the OR, is great. I think most people get intubated with propofol, right? They use propofol for most of the sedation.
Sorry to interrupt. I do have a question. If ketamine doesn't affect your blood pressure, why do you have a hypotensive dose on this side?
Oh, never really noticed that. Yeah, I don't know. Now I'll get a different table. It's supposed to be hemodynamically non-contributory, they say. So I've never even looked at those doses like that, but I basically just use a milligram per kilogram, and 2 milligrams per kilogram is quite a bit. So I think a milligram per kilogram is usually plenty, like 1.5 at the most, and then propofol like 1.5 milligrams per kilogram is plenty. Thanks for bringing that up. Like I put this table in like 4 years ago, but I never really looked at the doses too much. But 3 milligrams per kilogram of propofol is ridiculous. So anyway, I'm going to get rid of that table. But find an app on your phone or somewhere where you have the doses there, so you don't have to memorize them. But yeah, I basically use a milligram per kilogram of propofol, a milligram per kilogram of ketamine. I find that's usually more than enough. Some people love etomidate. I've just never got into it. Some hospitals love etomidate. I just don't. I've never used it. And Ketofol is great if you want to do sedations, like painful sedations work really well with Ketofol. Ketamine is my favorite for sedations. If something's going to be a bit longer, like a wrist or an ankle reduction or something, the big problem with ketamine in a rural place is it basically ties up a nurse for about 30 to 45 minutes because the patient takes that long to really recover usually with ketamine. So you've basically taken a nurse out of your emerge for that long, whereas propofol is usually done within 10-ish minutes. So it's logistically, it's way easier to use propofol when you don't have a ton of staff. Anyway, this is not an airway talk, but I just wanted to throw up the good old Mal and Patty so you can look at it and get a bit nervous when you're going to intubate this trauma patient with a facial injury. Yeah, there's all sorts of mnemonics out of there. I don't really use any of them. Have you guys had any mnemonics that you like? I put it up here just so people can look at it if they like. Again, I've never used any. If you have to intubate somebody, you have to intubate them. Like if they look like Santa and they have a beard and they have no neck and they're obese and they have dentures and they have facial trauma, that's going to be a difficult airway, right? For sure. But yeah, if you're going to do laryngoscopy, it's obviously nice to have a look and evaluate like the 3-3-2. People still use that. Like you're looking for 3 fingers here, 3 fingers there, and 1 finger of movement like that. And then you want to look at the Mal and Patty score, which is pretty hard to do under stress. And neck mobility. So that's another one. So neck mobility, they're often collared. Like most trauma patients that come in by ambulance are collared. If you cannot, and the glide scopes have changed airway. Like, I mean, I've only been practicing 6-7 years, and the glide scope has always been there. But you talk to folks that have been doing it longer, and before glide scopes changed everything airway-wise. Like, I think things like bougies are barely used anymore. Some of the older school ways of intubating aren't used too much by people like myself anyway, because glide scopes are just so great. And like even when people are collared, it's not too hard to get the glide scope in, right? But if you cannot get a view and they have a collar on, I've heard really experienced docs say take the collar off, hold in line, and if you have to manipulate that neck a little bit, then that's way better than just missing the airway. So I've been told that a number of times. So let's talk about a few bad airways. This is again, I took all these images from Google Image, but I saw a patient like this once who tried to steal power from an electrical box and got thrown like 30 feet. So when he presented to the emerge, he had a normal face just like you and me, and in about an hour his face looked like this. So this is a burn, an electrical burn. Has anyone ever seen a bad facial burn or airway burn? One of the things about them is they're tough. They're tough. So the thing about burns is when you do burns and you do the Parkland formula, right? You've heard of the Parkland formula. You're giving a lot of fluids, and when you are burned and you swell bad, and then you get a lot of fluid, you get edematous, and you'll see bad burn victims get quite edematous, and then they get otomies. I think that's the right term, right? Like you open up some of the wound and the scar, and it happens with the face too. So the fellow that I saw, I've seen a handful of these, but he swelled up like this pretty fast. So this is definitely a presumed worsening course, airway burn. And if you do some community emerge, you're going to definitely see some airway burns. I had one this week that I intubated, and they don't look that bad at first. And you have to make the decision that you're thinking, well, they look bad enough to intubate now. And one of the problems is you're not really going to know for about an hour. So I would say the absolute worst case I've had in my career was a airway burn of it was so sad, basically a family. and not many of them made it. But the dad made it, but had airway burns, and I really wanted to intubate him, and he's like, nope, no way, no way, I got to be there for my family and all that. And it's very noble and things, but I was pretty sure he was going to lose his airway, and he said no, 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 and he ended up being right. So we just watched him for a while, and he never swelled his airway, and he was never needed intubating. I've intubated a bunch of burn people for presumed worsening course that did not swell, and I've not intubated, I think, one that started to swell, and then we intubated them. But if it was me and I was in a burn and I had airway burns, I'd be intubated and I'd ride the vent for 2 days before I risked someone trying to intubate me looking like that. So when I had that case when the dad declined intubation, I got kind of upset about it because, like, in my own mind, like not upset at the person, but I really struggled with that case. It almost comes down to like a competency thing. Like, does this person have the wherewithal to understand the risk that they're in, and the potential consequence of it? And then you like versus consent, right? So it's one of those tough ones of competency versus consent. And I talked to like ENT after that. I talked to a legal person. I talked to an ethicist, and I talked to the burns ICU, and I didn't really get a good answer for what the indications are for intubating someone with a normal looking airway with risk of presumed worsening course. They were like, I mean, if you have soot and you have burned nose hairs, then it makes sense. But I never got a really good indication, so I can't really tell you a good indication for when to intubate these people early. Just that if you think they're burned around the mouth or the neck or the airway, I think it's better safe than sorry, is my opinion, because they do swell up really quite quickly. Any questions around airway burns? Upper GI bleed, or even just facial trauma. Like, so if they're vomiting blood or spitting up blood, which is quite common in trauma, like if they have teeth smash, or their teeth bite their tongue, the tongue bleeds quite a bit. Has anyone ever tried to intubate either an upper GI bleed or a facial trauma? It can be quite difficult. Probably the hardest part is you can't use the glide scope very well. So people like myself that become overly reliant on the glide scope can be a bit uncomfortable. I certainly really struggled with a couple bloody ones, because once the glide scope gets clouded and you can't see, my DL skills aren't that good anymore. Which is a good reminder. Whenever a couple times I've messed up some airways that are bleeding, and I wasn't that good at DL, like direct laryngoscopy, and some of the older school people are like, oh, you got to practice DL, and they say I always go into the OR and just do some direct laryngoscopy intubations just to keep the skills up. And there's value there. Something that I think none of us ever saw, because it never really became commercially successful, is the thing called a light wand. You guys ever heard of a light wand? It was actually a mentor of mine that invented it and then gave away the patent in like the 70s. So it's a bougie with a light on the end. So they did this in like the 80s. They put the bougie down with a battery powered light, maybe the 90s, I don't know. But I've only seen it used once. And you put the light down, turn off the lights in the room, and you'd see the light of the tip of the bougie light up on the trachea as it went down. And that's how you found the trachea, and then you put the tube over the light wand. So anyway, I saw it once. It's pretty clever, but I've never seen it again. The big thing about these is just suction, suction, suction. So suction, 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 try to get all the gunk out, and then I always just try to go in with the glide scope because I find it so much easier. Yeah.
Hey, Dr. Blacklock.
Yo.
I've seen as well, like with a glide scope, just like following in behind suction. So sort of have suction just ahead of the glide scope. Is that something that you'd recommend?
Yeah. Oh, for
trying?
sure.
Yeah, okay.
For sure.
Okay.
Yep. And I've definitely done that a handful of times. Like the first thing I usually like, you put the glide scope in and I lift the tongue up a little bit, and then I suction, because then you usually see a pool of fluid in the back of the throat. So try to suction, like, because you don't really want to ram your glide scope all the way in, because then it'll just run into the pool of fluid. So I just try to use the tip, pull the tongue up, suction, and then I put it down. Usually have like 5-6 seconds of a decent view, and then I try to be quick about it. That's usually my approach. And if it's bleeding bad enough that you don't have that 5 seconds, then you're in a bit of trouble. Yeah, then I would try again, and then I would try DL. And then there's other options. I mean, you can also put down an ET tube into the esophagus. So that's another thing. If you think the bleeding is coming from, like, say, the esophagus, or is more of an upper GI bleed, there's other things. I mean, you can use a Blakemore, but realistically speaking, probably you will have not used a Blakemore before, and the nurses will have not used a Blakemore before. And so Blakemores are great in lecture, but in practice, they can be a bit difficult. It's like one of those things that it's like a cric, right? Like in theory, everyone is an expert at cric because they've seen it like 50 times in lectures and sims, and it's great. And I'll tell you, it's not as easy as it is on a tissue box. But uh, it's the same thing with a Blakemore. Like I've only used it a few times, and it was even with the intensivist, it was a lot of learning. So anyway, my point is like obviously go for a Blakemore if you got it, but you got to be a bit realistic about where your skill set is. And if a Blakemore is like totally foreign and it's going to take you 10 minutes to figure it out, well, practice it beforehand if you can, like do an in-service or a sim with it or something like that, because it can be a life-saving thing if you can do it quickly. But the other thing I've seen done is just put an ET tube in down and blow up the bulb in the esophagus, because if you put it down blind, almost guaranteed you're going to get it in the esophagus, and then you can blow it up. And then that sometimes if the blood or fluid's coming from down there, you can usually buy yourself a little bit of time. You can put a suction down it too and try to suction it out. Remember, these are high acuity cases, so this is not a controlled environment. This is you're trying your best with what you can within like a minute or two. So I think you can get an ET tube into the esophagus a lot quicker than you can anything else. So I've done that a few times, put that in, blown up the bulb, got some local tamponade, put a suction catheter down, and then suctioned around the ET tube, and then that has bought me a bit more time before. So again, these are like rare cases, but that's why we're talking about them. Thanks, Paul. Any other questions about that? And one of the other big things is make sure you got a friend there. Like, try your best. I mean, if you're in a super small place without anybody, then so be it. But like, this is the last time you want to be a hero. Like, just call anyone. And then a couple times lately, I struggled with an airway last year that was probably the worst I've ever had. And thankfully, I called like 4 people in before attempting, and I was struggling, and the SATs were 40, and it was not going well. It was actually a epiglottis abscess. So I RSI'd a respiratory failure sepsis, young person, and then got in there and just saw this big bulging, it looked like a baby's bottom, just staring at it. I saw nothing but these big honking round tissues. And then the SATs were 40, and it was, difficult. 2 in the morning. And anyway, and then 4 of my friends, like 3 or 4 of my friends showed up, and it just all became better, so just call your friends is the point. Something like this. You'll see this sometimes. I've seen this a few times with a knife, and even more often with sticks. Like mountain bikers and things will fall, hikers will fall, and I've seen a number of times people get throat cuts. This is a bit dramatic, obviously, but it's a lecture. So yeah, this is patency. This is a patency problem. So we'll talk about this for a second. So the risk with neck trauma, and I won't go too much into neck trauma. Basically, there's 3 zones for neck trauma. And this is zone 2, this is the middle. The big problem here is you get laceration of vessels. You get laceration of everything, right? You get your carotid, your jugular, your trachea. If a penetrating trauma goes through the platysmus, you can risk hitting a vessel there, and you can get an expanding hematoma. You want to put pressure on that ASAP and take the airway. I've seen in a few of these expand, and then it just isn't very good when it starts expanding. So you try to get some abdominal pads on there. Don't remove the stick or the knife, just put some abdominal pads on there and try to get the airway best you can. I had intubated a couple people where the thing was actually sticking into the trachea, but was able to sort of work around it. So, and again, these are rare cases, but it's fun to talk about them. This is a patency problem. So this is the angioedema that you waited too long on, where they're in your ambulance bay, or you're in your trauma room, you're thinking, is it a big deal? Is it not a big deal? Maybe it's not a big deal. Maybe they're on an ACE inhibitor, or maybe they have a family history of some sort of congenital angioedema. Maybe it's a complement thing. Maybe I'll order a complement and consult internal medicine, or maybe it's an anaphylaxis. It doesn't go that well. That it wasn't that sick, and then it can become this. And I've had that a couple times. One quite notably, I quite ignored. I didn't think it was a big deal at all, and then all of a sudden it became this. And a colleague of mine, that was like my first week or month of practice, and it was a pretty bad mistake. And a colleague of mine thankfully intubated her with a nasal trach, like nasal bronch. So I was very impressed and owed that person. Anyway, yeah, it happened so fast. And anyway, so they put a 6-2, I forget, but they put a small tube on a bronch and put it right in and got it. So it's fantastic. Yeah, so crics, I'm going to avoid crics because we don't have a ton of time, but my lesson from the cric scenario not too long ago was a good tip was to use lidocaine with epi. So to because a buddy of mine did it not too long ago, and it was so much blood that they got in a lot of trouble just with all the bleeding. So putting lidocaine in with epi is something I'd never thought of before, and so I tried that last time, and it really helps limit the bleeding, just like in any sort of laceration or incision, right? It's just like doing an incision of a bad mole or something. So then at least you fill it up with lidocaine with epi, so then when you do the slice and the poke and the 6 tube over the bougie, it's really quite straightforward. So I thought the lidocaine with epi was a good one. So that's A. So that's 40 minutes talking about A. B. So airway, sometimes you can go through the primary survey within 2 minutes. Like it's like, IVO2 monitors, advanced airway to the bedside. You got A, their airways patent, protected, speaking full sentences, breathing, tracheus midline, good air entry bilaterally. SATs are 99%. And then you go through A, B, C, D, E, and you fast them, and you get a glucose, and you get a beta, and you're done. You're done the primary survey in 2 or 3 minutes. And sometimes you spend 40 minutes on A. Like I spent a couple hours on A a couple times. Obviously, didn't go so well. But so breathing. So what I want to hear if I'm the leader and you're the worker bee is, the trachea is midline, there's good air entry bilaterally, the lungs are clear, the SATs are this. Maybe you put an ultrasound on, you see bilateral lung sliding. If not, something needs to happen. And the joke I like to make is the most common reason for decreased air entry bilaterally is usually the stethoscope's turned around the wrong way, either by myself or the resident colleague. So definitely, I've seen that a few times for sure. And sometimes the ET tube or things is clogged or it falls out of the wall. But we'll talk about pneumothorax and hemothorax. I've seen some diaphragm rupture too and some Borges. Those are pretty gnarly. But pneumo, let's talk about pneumo. So pneumos are quite common in trauma, even just spontaneous pneumos you'll see. Have you guys all had a chance to put in a chest tube or a pigtail? Hopefully you have. It's not too hard. If you haven't, there's a chest tube trainer in the sim room there. So you can always make an appointment down with Michael Lendine or them to practice with the sim chest tube trainer, which is quite good. Here's a hemothorax. It's hard to tell on an x-ray what's a hemothorax, what ends up being more like malignancy or tumor or pleural effusion or atelectasis, but in a case of trauma, something like that, that would be a hemothorax. So yeah, so putting a chest tube in is quite simple. You feel, there's different ways to do it, but I still like to do it the old, like the old classic way is you go anterior axillary line, right? Fourth intercostal space, so you kind of go nipple line, anterior axillary line, and then you feel right above there, and then I put the freezing in, and then you do a little like 2 centimeter laceration, then you get in with the Kelly's or mosquitoes, and you rip, 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 and then you get down to a rib, and you got your curved little, I'm blanking on if that's a mosquito or a Kelly, but you've got your curved little instrument there, and then you get on top of the rib, so you usually hit a rib usually, and then and some people you'll find have huge space between the ribs, and some people I like to joke are like, they're like fish, like there's no space between those ribs, but hopefully you got a bit of space between that rib. So you, if this is the rib, that makes sense, right? So you're tear, you hit the rib, and then you go on the top, and then you pop, and you puncture through the pleura. It takes way more force than you think. So if you've never done it before, it's like an uncomfortable amount of force. But the key to puncturing the pleura is you have to make sure. People get excited sometimes and get to that point and don't have any of the other stuff prepped. So if you puncture the pleura, you've essentially stabbed them in the chest. And you have to be ready with that chest tube. So before you do any of the freezing or cutting or tearing, you have to prep your tube. So you get your chest tube, you take the metal trocar out if you want, and then there's a couple ways to do it. Either you can put your little mosquitoes or Kellys into the last hole of the chest tube and clamp it, and then you can use that to follow it along your finger. Or some people leave the trocar in. And if you're going to leave the trocar into the chest tube, so when you open a chest tube, this is the chest tube, and this is the trocar. Do you guys know what I'm talking about? There's a metal, essentially, spear inside the chest tube. That's how they come. So you open the package, you pull out the chest tube. The chest tube has a metal rod in it with a point. Looks like a big javelin. So, and it sticks out like a centimeter of the chest tube. So what you got to do is you got to pull that back so it's flush with the bottom of the chest tube, because you don't want to, if you're going to use the trocar to push in the chest tube, you don't want this big stake sticking out 1.5 centimeters that can potentially puncture a liver or a heart. So you want to pull it back flush with the chest tube and then clamp. I like to pull it back flush with the end of the chest tube and then clamp it at the top of the chest tube, like with a Kelly, so it won't slide. And then Then now your chest tube is ready. And the other thing you want to make sure you have ready is your suction, like your suction box. So whether you're going to go to wall suction or the underwater suction box, you want to make sure that's ready, because the last thing you want is to put in the chest tube and then it pours out blood, for example, and then it's just all over your feet and legs and the floor, and you've got nothing to attach it to, because then it's essentially just an open cavity, which you don't want. So yeah, so have all that prepped, and then you get over top of the rib, pop, and then you can spread just a little bit, and then you try to get your finger in there, hold your finger, and then you can put the chest tube over your finger, or you can hold the Kellys there in the hole and run your trocar embedded chest tube over the tool, and then unclamp the little thing and slide it off. Really quite easy. Easy to say, but it definitely takes 5 or 10 to really get confident at. But yeah, use the chest tube trainer. Any questions about chest tubes? Great. So yeah, so that's B. Again, we could talk about all of these all day, but we won't. So ABC. So when you're the worker B, you're going to do S1, S2, no murmurs, peripheral pulses are palpable, there's no cyanosis, blood pressure's this, heart rate's that. And if there's a problem, what are we going to do about it? Usually it's hypovolemic shock is the problem. So in bleeding, in trauma, either you're bleeding inside or out. So for example, this patient on warfarin that I mentioned, they were bleeding quite a bit into their abdomen, which isn't good. So the first thing you want to do is the obvious stuff. You want to bind any sort of things that are broken, right? Like, so if you have a femur fracture that looks obvious, femurs are a bit tough because you do want to splint it, but that does take a bit of time. The first thing you want to do if you have an open gushing wound is put like an abdominal pad on there, or pressure dressing, and wrap that up. Like first thing first, like if they're coming in with a big cut or an amputated limb, you want to try to either tourniquet that right away or put a pressure bandage on it right away. Like binding a femur fracture takes a bit of time, so I wouldn't rush to that quite yet. Binding the pelvis is quite quick. Often paramedics will do that at the scene, but if they haven't bound the pelvis and you think there's a pelvic fracture, then just bind it. If one person pushes on the anterior superior iliac crest and it feels any sort of laxity there, that's a pelvic fracture. And don't let every resident student like feel that laxity. Bind it. So whether you use one of the commercial Velcro cinch-up binders or you just use a sheet and you pull it and you wrap it, and you just YouTube these things. So YouTube like the commercial binders, figure out what you have in your place. Prince George has the paramedics, last I checked, had the Velcro cinch-up ones, which are beautiful. Some places don't have them, and then you're just using a sheet. So just Google like watching people put them on, because it's not super intuitive in my opinion. And like I've always struggled with it if I haven't done it in a little while. It's just you have to remember, and then the second time you do it, it's super straightforward. So yeah, binding the pelvis, splint the fractures, put compression on the bleeding things, and then you want to give blood if you have it. So 2 large bore IVs is great. Easier said than done, as you know, especially when people are a bit peripherally shut down in trauma. Getting an IV can be very difficult. And so if it's like 2-3 attempts and they can't get that IV, again, like I said before, just do an IO and move on, because you can mess around a long time with a peripherally shut down hypovolemic patient not getting an IV. If you have small places like Powell River, usually have 2 or 4 units of blood. Prince George would have more than that, but they'd have that thawed. So I'd call for that right away, and I'd get 2 units in as quick as I could, and then another 2 units in as quick as I could. You can give a liter of fluid, but you don't want to give really any more than a liter in trauma. And you want to give TXA, just to give a gram of TXA up front. And then this patient I was talking about, for example, they're on warfarin. So what are you going to do about that? Has anyone dealt with a life-threatening bleed on warfarin? You give Octoplex. So Octoplex, I mean, you can give vitamin K, like you can give 10 milligrams of vitamin K, but that takes like 4 to 6 hours. Octoplex is the vitamin K dependent clotting factors, and that's a blood product. When I asked for it in this case, I think it took half an hour. So, bigger places would have it thawed. I'm pretty sure it was frozen. Don't quote me on it because I don't remember, but it wasn't instant, that's for sure. Yeah. So just keep you got to keep that in mind. It's not like a sim, right, where the whole case is done in 10 minutes and you've got the massive transfusion protocols running, the FFPs running. That's frozen too in most places. That usually takes about 45 minutes. It takes 45 minutes for us to get. The Octoplex is not instant. Only thing that's instant usually is a bit of O negative blood. Unless you're in a big hospital that keeps that stuff not frozen, but not frozen has a limited shelf life. Again, I'm not a transfusion doctor, but I do this enough to know what I can get fast and what I can't get fast. So I can get TXA fast, I can get 2 to 4 units of blood fast, but after that, it does take a little bit of time. So massive transfusion protocol, you'll probably hear that overhead. Do they still call that overhead in Prince George? Massive transfusion protocol, OR6 or trauma room, and I've definitely called my share of those. The nice thing about calling massive transfusion protocol, at least in Prince George, is the hemopathologist would phone you, and that was always kind of nice. They would call. I think they were usually in Vancouver, I forget, but they would call and they just like run the case with you in like 30 seconds. Be like, what are you dealing with? What do you need? And they really helped. So that was a really nice thing to do. That was part of the Prince George program, if I recall, if it's still like that. But you basically want to, if you think you're losing anywhere in the, if you just think you're losing a lot of blood, I would just initiate it. Like you can always cancel it. I think I've probably canceled half of the ones that I've ever called. And it's not a huge deal. They just pull some, again, I'm not a transfusion doctor, so I shouldn't speak too confidently on it, but like they're going to activate lab, they're going to activate the hemopathologist, they're going to reserve some blood for you, and they're probably going to pull some out of the freezer and start warming it, I think. So not a big deal if you cancel it. I'd rather cancel it if I didn't need it than not have it and do need it. You know what I mean? So yeah, 4 units of blood, and then you want to try to get the 1 to 1 to 1, like the 1 packed red cells to 1 FFP to 1 platelets as soon as you can. There's big documents like this, and there's one in the Prince George trauma room, if I recall. Like there's 2 posters, I think, even on the wall to the trauma room. At least there used to be. This is not the Prince George one. I just took this online, but just to give you an example of how specific it can be. Like, you know, a lot of really smart people put a lot of energy into massive transfusion, and I'm just not one of those people. But there's all sorts of problems when you start giving lots of blood, right? You can get acidotic, there's temperature problems, there's clotting problems, but you need that preload, you need that blood, you need that in the pipes of the human body, otherwise it's going to shut down, right? So yeah, so that's massive transfusion and that's circulation. And I think we're going to stop there. Yeah, we're going to stop there. So that's trauma part 1 from the RTVS program. Thank you very much for coming. And sometime later this year, I'll do trauma part 2, which will be the rest of it. So again, I'm not a trauma expert. I'm a GP that's allowed to do full-time emerge, but I'm not trying to be a trauma expert. I'm just trying to communicate, like, if you can learn the basics of trauma, then you can practice the basics of trauma and you can do a really good job for your trauma patients. You don't need to be superstar or nothing. You just need to do basic good logistics in trauma, A, B, C, D, E. And so if you guys can just review the primary survey, I think it's good that we've talked about it today. Just review what a primary survey looks like, YouTube it, watch some people do it, try to do it on some mild trauma patients, and then we'll talk about the rest later. But it's just a practice thing, and then it gets pretty easy. Any questions?
Yeah, Dr. Blackwell, I had a question just about the massive transfusion protocol. Do you ever use or give much weight to the like ABC score for triggering that? Like I know it's on MD Calc. It's like, you know, blood heart rate over 120, blood pressure under 90, so on and so forth. And if you get 2 or more out of the 4, then you should call it. Like penetrating trauma zone.
To be honest, I've never heard of that score. I've heard of but that's not saying much. But there's definitely like the categories of hemorrhagic shock. Like there's like grade 1, 2, 3, and 4. I think that's on like med school exams and things. So I mean, what you're explaining is you're explaining tachycardia, hypotension, like you're explaining pretty legit hypovolemic shock. So if you're suspecting hypovolemic shock, to me and you have a cause of bleeding potentially uncontrolled, I think that's a fantastic indication. But yeah, I don't know that score. I'll check it out though, Paul. That's good. But yeah, anything that looks at all like hemorrhagic shock, I would initiate it, because the last thing you want to do is give a bunch of fluids, right? That's what they used to do in the old school ways, and that did not work out well for mortality.
Right.
As tempting as it is.
Yeah, gotcha. Cool. Okay, thanks. Yeah, thanks very much for the lecture.
Yeah, thanks everybody. I'll see you guys a little later, and feel free to call Rudy anytime. You can get a hold of the RCCBC. You can make your free account. You can just call them in the day and demo it, and Rachel is going to help me organize a sim there at some point for you guys where you practice calling RTVS. So thanks, and bye-bye.